Good afternoon. So today's topic for discussion is phase 2 periodontal therapy. So before this, we will discuss about the treatment plan. What are the steps? What are the different phases in your treatment plan? So as you know, according to treatment plan, there are four there are four phases of treatment plan. The first is your preliminary phase or comes your emergency phase. Second one is your phase 1 therapy or non-surgical phase. So in phase 1 therapy, usually non-surgical periodontal treatments are performed. The next comes the surgical phase, or it is also called as phase 2 therapy. Then comes the restorative phase, it is also called as phase 3 therapy. And the last one is phase 4 is maintenance phase. What procedures are included in each phase? So now coming to emergency phase. So whenever patient has emergency of any dental treatment, for example, periodontal abscess or periapical abscess or any pericoronal abscess. So these patients usually are treated in preliminary phase or emergency phase. Second one is also some patient may complaints of grade 3 mobile. So whenever the patient has prognosis of teeth, those teeth usually are extracted during your emergency phase or preliminary phase. The second phase is phase 1 therapy, that is non-surgical phase. So in this phase, usually non-surgical periodontal treatments are performed. For example, in this we perform scaling, root cleaning, then various plaque control measures, patient education, and correction of any restorative and prosthetic irritation. For example, retentive factors like subgingival overhanging restorations. Then in non-surgical therapy, we also do excavation of caries and restorations. Then antimicrobial therapy, as we have discussed, antimicrobial therapy, it may be localized antimicrobial therapy or systemic antimicrobial therapy. And various type of occlusal therapies. For example, if there are also, minor orthodontic treatments are usually performed in phase 1 therapy and provisional splitting. For example, if patient has grade 2 mobility and it is difficult for performing scaling and root cleaning, so in those phases we perform provisional splitting. Second phase is phase 2 therapy. Today we are going to discuss in detail about the phase 2 therapy or surgical phase. So whatever surgical treatment we are going to carry out are performed in this phase 2 therapy or surgical phase. For example, periodontal therapy, including the placement of implants. All periodontal treatments are performed, whether it may be minor or major. Minor includes various gingivectomies, gingivoplasties, and major includes various flap surgeries as well as various surgeries that are performed, periodontal plastic surgeries, usually are included in phase 2 therapy. Then also comes the endodontic therapy. So endodontic therapy is also performed, uh, root canal treatment is also performed in phase 2 therapy. So next phase is phase 3, that is restorative phase. So in restorative, we are doing final restorations, also fixed and removable prosthodontic appliances, and evaluation of response. So previously, the treatment plan was initial phase, uh, emergency phase, followed by initial, then it was phase 2 therapy, surgical phase, restorative, and maintenance. But according to supportive periodontal therapy, after each phase, we are performing the maintenance phase. That is, when you are doing emergency treatment, when you are performing non-surgical phase, then it is followed by your maintenance phase. After maintenance phase, you are performing surgical phase, and surgical phase is also followed by your maintenance phase. So now the triad has been changed. After each phase, we are performing the maintenance phase. That is comes under the supportive periodontal therapy. So there is a trimeric model representing. So So what are the synonyms for phase 2 therapy? So phase 2 therapy is also called as a surgical phase. So what procedures usually are performed in phase 2 therapy? So it may be open view operations, for example, to access to the diseased root surface without soft tissue excision. So we are doing here uh, deep curettage. So these are open view operations. Second one is excision of diseased gingiva. So this includes gingivectomy procedures and to reshape the gingiva, we are performing gingivoplasty. Also, we are performing tap surgery procedures. So here we are exposing, there is exposure of bone and we are performing instrumentation. And there are some various periodontal plastic surgery. This surgery usually are tailor-made techniques. So tailor-made techniques includes widening the zone of attached gingiva and various regenerative procedures usually are performed in phase 2 therapy. Now coming to what surgical procedures, periodontal procedures are performed in phase 2 therapy. So there are two types of uh, periodontal surgery. Includes one is pocket reduction surgeries, and second one is correction of anatomic or morphologic defects. So in pocket reduction therapy, again they are divided whether it is resective type of surgery or whether it is a regenerative type of surgery. So in resective, we perform gingivectomy, flap surgeries with or without osseous resection, undisplaced flap, and apically displaced flap. So this comes under resective type of periodontal pocket reduction surgery. Second one is regenerative therapy. So regenerative therapy, usually we use flap surgery with or without with bone grafts and with various types of GTR membranes. So these therapies usually are pocket reduction therapy. Now coming to second is periodontal surgery is correction of anatomic or morphologic defects. So in anatomic or morphologic defects usually are caused in periodontal disease. One is first surgery we use is periodontal plastic surgery. So periodontal plastic surgeries are mainly used to widen the width of attached gingiva. It can be done by various periodontal plastic surgeries with the help of pre-gingival grafts or various connective tissue grafts. So these grafts are usually used in periodontal plastic surgery to correct anatomic defects, for example, gingival decisions. Then we do aesthetic surgeries for root coverage, or in case of maxillary anteriors, we perform papilla preservation surgery. So this comes under aesthetic surgery. Then we perform pre-prosthetic surgeries. For example, whenever there is inadequate crown height, we perform crown lengthening procedures. Also, whenever you are giving a fixed partial dentures, there is irregular due to extraction of teeth, there is irregular ridge. So to compensate this, we are performing ridge augmentation surgeries. We are placing soft tissue graft from the palate region and we are placing onto the ridge so that there is even margin of the gingiva. Then comes whenever there is inadequate vestibular depth. In those cases, we perform vestibular deepening procedure. It is also called as vestibuloplasty. So in those cases, or sometimes whenever you are planning for complete denture patients, whenever there is more amount of region resorption, in those cases also we perform vestibular deepening. So for better retention of your complete denture, then placement of implants are usually performed in also some implants as well as GPR, that is bone guided bone regeneration. So whenever you are placing implants, whenever the buccolingual width of your alveolar bone is less, in those cases we are doing GPR. So guided bone regeneration surgeries are also performed during your phase 2 therapy. Then comes sinus lift. Whenever there is inadequate height for placement of implants in your maxillary posterior region. So in those cases, we are performing sinus lift procedures or sinus grafting. So sinus lift procedures are of two types. It may be a direct procedure, sinus lift, or indirect sinus lift. Okay. So we will discuss more in detail about these procedures individually in your separate lectures are there for this procedure. So So there are some criteria that are required for method selection. So one is characteristics of your pocket, whether the depth of the probing pocket, whether relation to their bone and configuration. So second criteria is accessibility to instrumentation, including presence of percussion. Whenever percussion involvements are there, those percussion involvements are difficult for instrumentation during your surgical non-surgical phase. So for those inaccessible areas, we usually perform phase 2 therapy, that is surgical phase. Then existence of mucogingival problems. So mucogingival problems usually are whether there is aberrant frenum. Whenever there is aberrant frenum, we go for frenectomy. Then response to phase 1 therapy. Then patient cooperation, including ability to perform effective oral hygiene. Smokers must be willing to stop their habits. So this usually is carried out during your phase 2 therapy. Then overall diagnosis of the various types of gingival enlargement and types of periodontitis. Based on this, we are uh, selection of the patients, the previous periodontal treatment, whether patient had previously performed. So these patients usually are considered before this planning for phase 2 therapy. Then what is the time lapse between your initial phase, that is phase 1 therapy and phase 2 therapy? So whenever you are perform phase 1 therapy, there should be a time between these two therapies. So the time may vary from 1 month to several months, depending on the clinical signs and symptoms of the patient, whether the case is of mild gingivitis, whether the case is of mild periodontitis, severe periodontitis, or moderate periodontitis. Depending on these clinical features, we are the time lapse between your initial therapy and phase 2 therapy should be considered. So it may usually 1 month to it may take up to several months. So removal of calculus and bacterial plaque. There is usually after removal of plaque and calculus in the non-surgical phase, there is reduction of inflammation. Then there is we can access true pocket depths can be accessed during your phase 2 therapy. In reduction of inflammation, the pocket becomes more fibrous and firmer. There are less chances of your bleeding, and we can manage the tissues in a better way. So tissue management can be better during your phase 2 therapy, that is surgical phase. The evaluation of patient's effectiveness, whether the patient is maintaining oral hygiene measures, because whatever patient, so this is an important factor for the long-term prognosis of the tooth. Then what is the purpose of phase 2 therapy? So the main first purpose of phase 2 therapy is controlling or eliminating the periodontal disease. Whatever periodontal disease is present in patients, uh, that we have to control and eliminate we have to completely eliminate the periodontal disease. Second one is correcting anatomical conditions. Whatever anatomical conditions or iatrogenic factors are present, we have to correct that so that it does not lead to the progression of the periodontal disease. So, correcting anatomical conditions that may favor periodontal disease, that may impair aesthetics and placement of correct prosthetic appliances. Whatever these anatomic conditions we have to correct while performing phase 2 therapy. Then implant placement and implant related surgeries have to be performed. So these procedures have to be performed during your phase 2 therapy. Then what are the objectives of surgical pocket therapy? So whatever, as you know, periodontal disease, usually clinical signs shows presence of pockets. So our objective of surgical therapy, pocket reduction, should be either the pocket should be reduced or the pocket should be completely eliminated. So objective is to eliminate pathologic changes in the periodontal pocket wall. Whatever bacteria have invaded the pocket wall, we have to just eliminate those pathologic conditions in the pocket wall. Also to create a stable and easily maintainable periodontium. So after performing phase 2 therapy, we have to just create a stable and easily maintainable periodontium for the patient. And third objective is to promote periodontal regeneration. Whatever bone loss has been occurred, we have to just regenerate that bone as well as soft tissue for to regenerate that therapy. Then correction of anatomic or morphologic defect that may favor plaque accumulation, recurrence of periodontal pockets, and impair aesthetics. Hence, the objective is not directed to treat the disease but aim to alter the gingival and mucosal tissues to correct defects that may predispose to the progression of your periodontal disease. So these are performed on non-inflamed tissues and in absence of any periodontal pockets. So what is the need of surgical treatment? The first need is impaired access for scaling and root planning. Whenever your patient is having deeper periodontal pockets, if you are perform good scaling and root planning, there is impaired access for scaling and root planning. For this purpose, we are exposing the flap so that we can access, have a good access or instrumentation to underline root structure. So increasing depth of periodontal pockets, teeth with wider surfaces, presence of root fissures, root concavities, percussions, or defective restorative margins. So these patients usually you are placing on for surgical treatment. Then impaired access to of self-performed plaque control. Whenever patient has lack of patient education and motivation or lack of manual dexterity, for example, in case of patients who are physically handicapped patients, in those patients usually we need surgical treatment of periodontal disease. Then in case of gingival hyperplasia cases, whenever patient has greater formation and faulty restorative margins, whenever there is subgingival overhanging restoration, in those cases we have to expose those area and we have to perform to correct the overhanging restorations. We are using surgical treatment. So various authors have given various studies. So Warhol and Capesi. So these were the authors with correct techniques and suitable instrument pocket depth. Uh, so according to these authors, normally in non-surgical periodontal therapy, the clinician will have will suitable instrumentation for pocket depth up to 5 millimeter of pocket depth can be obtained. However, it cannot be considered as a rule of thumb. Reduced accessibility hinders proper debridement of shallow pockets. So good access and favorable morphology allows complete debridement of your deep periodontal pockets. So what are the indications for coming to indications of periodontal surgery? So first indication is areas with irregular bony contours, deep craters, and other intrabony defects. So areas with irregular bony contours, deep craters, and various intrabony pockets. These are the patients who are indicated for periodontal surgery. Then pockets on teeth in which complete removal of root irritate is not considered clinically possible, frequently in molars and premolars. Whenever the clinician is pocket depth is greater than 5 millimeters, those pocket depths usually are very patient has clinician usually has difficulty in accessibility. So to have a complete accessibility to the root surface, these patients usually are indicated for surgery. Frequently, usually we use in molars and your premolar areas. But because these regions teeth are more inaccessible, have more inaccessible areas. In case of percussion involvement of grade 2 and grade 3, usually we perform root resection or resection. Then comes the intrabony pockets on distal surfaces of your last molar. We are performing distal molar surgeries for these tooth whenever there is intrabony pockets on your distal areas of your last molar. Then patients indicated with persistent inflammation in, in areas with moderate or deep pockets may also require a surgical approach. And the last indication for periodontal surgery is in areas with shallow pockets or normal circi. Persistent inflammation may point to the presence of a mucogingival problem that needs a surgical solution. Whenever patient has shallow pockets, but in spite of shallow pockets, usually there is complete persistent inflammation. So it indicates that there is somewhat mucogingival deformity is present. So in those cases, also we require periodontal surgery. So before performing periodontal surgery, we have to consider whether the patient is having poor compliance. If the patient is poor compliant, then those cases should be contraindicated for your surgical therapy. The patients who are having history or habit of smoking, then those patients usually have to be uh, contraindicated before performing any periodontal surgery. General health of the patients. Usually, medically compromised patients, we have to take consult of your consult of their physician. So before performing surgery, we have to perform. We have to consult with the patient's physical physician or patients who are medically compromised patients. Then, as we know, while performing any periodontal treatment, we are anesthetizing the local area. We are administering the local anesthetic agents. But while performing, we have to take some points into consideration while administering local anesthesia. Because if you inject more amount of local anesthesia, usually there is ischemic necrosis of flap occurs, lubricant infiltration with local anesthesia containing non-epinephrine as a vasoconstrictor. So infiltration only as needed, and it should not be a habit. Whenever there is need of infiltration, we have to give infiltration and not give as according to your habit. Okay, so up till now we have uh, discussed about various phases of uh, treatment plan. Then we have discussed what are the surgical techniques, periodontal surgeries that we are going to perform during your phase 2 therapy. Then what are the indications of periodontal surgery? Now coming to what instruments are used while performing your periodontal surgery. So there are various instruments that are used during your periodontal surgery. So there are various incision and excision instruments, that is periodontal knives. Then various deflection and readaptation of mucoperiosteal taps is usually carried by periosteal elevators. Periosteal elevators usually they are used for reflection of your flaps. Then removal of adherent fibrous and granulation tissue is carried by various soft tissue scissors and your soft tissue rongers. So in those cases, we use whatever inflamed periodontal pocket lining is present. We are just removing with the help of your tissue nippers and your soft tissue scissor. Also, in case where there is uh, irregular bone, we are using burrs and various bone files and Austen beam scissor. Then various scaling and root planing instruments, that is scalers, and various types of curates are used for root planing, that is Gracie's curate, or you can use universal curate for your root planing. The removal of bone tissue is usually carried out by bone rongers, scissors, and various files. So bone files usually are Sugarman's bone file and Sugar's bone file. Then root resection or sectioning is done with the help of your diamond burrs. Then suturing, for suturing purpose we require sutures, needle holders, and scissors. For suturing, there is various, you can use absorbable sutures or non-absorbable sutures can be used for performing periodontal surgeries. Then after suturing, there are some periodontal dressings are usually used nowadays after performing any periodontal surgery. So application of wound surgery is done with the help of any plastic instruments. So whatever periodontal dressings you are going to give after performing periodontal surgeries, for this purpose we are using plastic instruments. So these are the various instruments that are used while performing periodontal surgery. So what are the advantages of performing phase 2 therapy? So after performing outcomes of phase 2 therapy, so outcome is there is increased accessibility to the root surface therapy, thereby easily removable of your irritants like plaque and your calculus. Second one is There is reduction or elimination of pocket depth to a depth of normal sulcus that can be maintained by the patient. Also, you are reshaping your hard tissue and soft tissue to maintain a harmonious topography of your alveolar bone. So these are the outcomes of after performing a successful phase 2 therapy. We can see there is reduction in amount of periodontal pocket to a pocket depth that can be maintained easily by the patient. There is increased accessibility to the root surface, for example, in molars and premolars, and also in cases where there is percussion involvement, and also there is reshaping of hard tissue and soft tissue to attain a harmonious topography. Then clinical outcomes of surgical therapy in comparison to your non-surgical therapy. So whenever you are performing phase 2 therapy, there is more amount success is achieved by surgical therapy can be best evaluated by duration of tooth retention. But it needs extremely long follow-up period. Considerations of surrogate endpoints is there is resolution of gingivitis, there is resolution of your bleeding on probing, then there is pocket depth reduction, and changes in clinical attachment level. Sometimes we see clinical gain, and also the gingival recession also affects the overall perception of your patients. So there is a misconception regarding whether we have gain, there is attachment gain, or there is pocket closure. Pocket closure. So clinical attachment loss in attachment is a true loss of connective tissue attachment, whereas gain is false gain due to reduced penetrability of connective tissue affected to the bottom of the pocket after periodontal treatment. Because after periodontal treatment, the inflamed pocket lining becomes more fibrous, so the penetration of your periodontal probe doesn't occur. So there is usually a misconception that after periodontal therapy, attachment gain has occurred. So this doesn't occur, but there is more fibrous. The post-operative infection controls implies a relative effect of surgery. So various authors have studied after performing phase 2 therapy, uh, uh, some patients were placed on only pre-operative OHI and not post-operative. So these patients showed that there is rebound of pocket depth with clinical attachment loss. According to Roslin, this was the author who performed pre-operative OHI as well as post-operative OHI. So, and the patient usually were kept on professional teeth cleansing every 2 weeks. So these patients showed that surgically reduced pocket depth and clinical attachment gain. So Linde was the author who performed a 5-year longitudinal study. The patient with high standard of plaque control maintained clinical attachment levels and probing depth reduction following treatment more consistently than patients with poor plaque control. If the patients has poor plaque control, the patients are more liable for recurrence of periodontal disease. Then after periodontal therapy, we have to evaluate first phase 2 therapy. We have to in maintenance phase we have to evaluate the clinical signs and symptoms, whether the bleeding or probing is present, whether inflammation is present. Then probing pocket depth reduction we have to evaluate during your uh, maintenance phase. Then changing clinical attachment level, whether the patient has gained any clinical attachment gain has occurred, we have to evaluate during your maintenance phase after phase 2 therapy. Then gingival recession. After performing periodontal surgery, bone loss has occurred. Then after performing surgery, we can see there is some gingival recession occurs after phase 2 therapy. So we have to evaluate this during your maintenance phase. So this denotes that the ultimate goal of periodontal therapy, that is regeneration or entire lost periodontium, occurs. The healthy gingiva can be located coronal to the bottom of the pocket, resulting in surplus of normal depth with gain of attachment. Then we have to evaluate for whether there is any bone field in angular bone defect. After performing phase 2 therapy, if you are doing regenerative therapy, then we have to evaluate for any bone field. Whatever bone loss has occurred, that bone gain has occurred or not, we have to see during your maintenance phase. Okay, so this is all about your phase 2 therapy. Then we are performing various endodontic treatments, that is root canal openings as well as BMPs are performed during your phase 2 therapy. So this is all about phase 2 surgical therapy related to periodontal therapy. Okay, so coming to conclusion, phase 2 therapy is an adjunct to your phase 1 therapy. So before performing phase 2 therapy, we have to perform phase 1 therapy. Various surgical methods in addition to this phase 2 therapy is used as an adjunct to your phase 1 therapy. Okay, so this is all about your phase 2 therapy. So while recording case history and while you are doing treatment for any periodontal therapy, you have to write what treatment you are going to give based on your clinical findings, whether the patient needs periodontal reduction therapy, whether the patient needs periodontal elimination therapy, or there are some therapies to correct anatomic or morphologic defects that may be required periodontal plastic surgeries. So these all procedures should be written while you are planning treatment, when you are writing your treatment plan. Okay, so this is all about phase 2 therapy. Any queries?
सर इन्फ्राबोनी पॉकेट साठी कोणती थेरपी सांगायची?
कोणती?
इन्फ्राबोनी पॉकेट साठी.
So infrabony pockets usually requires flap surgeries with bone grafts and GTR membranes. Whenever intrabony pockets are present, so intrabony pockets, classification of intrabony pockets is based on your presence of wall. Whenever there is presence of one wall pockets, it is classified as one wall defect, then two wall defects and three wall defects. So based on your intrabony pockets, whether it is one wall defect, two wall defect or three wall defects, based on this we are performing regenerative therapy. So the prognosis or more chances of regeneration are in three wall defects, because your natural three walls are present. We are placing bone grafts and we are placing over this bone graft, we are placing membranes. So we have to reflect both the flaps and we have to perform regenerative therapy. Here, in case of one wall defects, there are less chances of regeneration. So in those cases, we are doing resective therapy. Okay, so resective therapy is carried out because to eliminate your periodontal pockets, because only one wall is present, rest all walls are missing. So in those cases, there are less chances of regeneration. So we have to create, or your aim in periodontal surgery is for elimination of your periodontal pocket. So this pocket can be reduced by performing resective periodontal resective surgery, resective osseous surgery. Okay, so whenever intrabony pockets are present, you have to go with either regenerative therapy or either with resective therapy. So for doing this both therapy, we have to reflect the flaps. Okay.
Okay, sir.
Any doubt?
No.
Okay, so while recording case history, you have to write these surgeries based on your clinical findings. Okay, if there is pocket depth, you are having pocket depth greater than 5 mm, that means we have to go for your pocket reduction therapy. Okay, we have to perform various flap surgeries, but you can write just flap surgery instead of, because there are various surgeries that reduce your pocket reduction. Okay, so apically displaced flap is considered as your pocket reduction therapy. Okay, so it completely eliminates the pocket, whereas modified Whitman flap is considered just your pocket reduction therapy, whereas apically displaced flap is your elimination therapy. Okay, based on this, you can just put flap surgeries with so and so number of teeth. Okay, any queries?
No, sir.
Okay.